advances in stroke management. So a few disclosures that I've got, nothing that's really terribly relevant to what we're doing now. Involved in development with several device companies for things, but that's I'm not going to be showing any of that. So let's start at the beginning. So neurosurgery is really no stranger to stroke management, but our options have really changed over time. I think that's where things have differed. So, this is a picture used with permission from a few years ago. Young woman, vital, prime of her life, comes in with sudden onset of left body symptoms, right M1 occlusion. And you can see here, this is sort of what the neurosurgeon would have thought, 10 years ago. You look at the first scan, you say, looks pretty good, we're gonna watch it. Day 2, you see a whole bunch of swelling. I'm just gonna turn on my laser pointer here. You can see this area on the right hemisphere that's sort of evolving MCA stroke. By day 4, we're now prime swelling. So swelling peaks 48 to 72 hours out. This patient underwent hemicraniectomy. This was what surgical management of stroke looked like, 10 years ago. And this is a decompressive hemicraniectomy. Not a very good one for that matter, but this is kind of what it looked like. And this is how the patients did. You can see here, she survived. She's definitely got deformity. You can see the paralyzed hand. This is not at all what she was expecting out of her life, and it's not something that we as neurosurgeons want to do for our patients if we can do otherwise. But fortunately, times are changing. This is not sort of the state of the art. This is 50 years ago type neurosurgery, and we can do better now. Right. So let's break it down into the two categories. Far and away, ischemic stroke is the most prevalent stroke type. Hemorrhagic stroke only accounts for about 13%, but that's sort of the variety of stroke that captures most neurosurgeons' imaginations, at least heretofore, because that's where the sexy stuff was, the aneurysms, the AVMs, the cat mouse, things like that. But, of the 700,000 people per year or so who suffer stroke, the vast majority are ischemic stroke. And there's our biggest opportunity for public health impact. When you think, so in my other job, I'm a data scientist. When you think about where neurosurgeons can make an impact in public health, there's TBI, there's stroke, and there's low back pain, right? Those are the really big things that we end up dealing with. Otherwise, neurosurgery, the GBMs, the aneurysms, all that is noise in the healthcare system. It does not account for much in terms of a public health impact. So this is acute ischemic stroke. It's the 3rd most common cause of death in an industrialized nation. Single most common reason for permanent disability, and there's a huge cost, not only in terms of lives, but in terms of dollars, measured in the tens of billions. Okay. This is only supposed to get worse as the population ages. Obviously, age is a significant risk factor with vascular disease in general. And as the population ages, the prevalence is going up. And important to know is what we are fighting against. In any disease process, what we are fighting against is the natural history. And these are the outcomes after ischemic stroke. You may have talked about this in prior sessions, but I'll just go over this real quickly. Discharge to home before the modern thrombectomy era, 3.3%, right? That's terrible. And most folks would have significant disability or death, a quarter dying, as you can see here. Those are terrible odds. That's not something that there's opportunity for improvement there, opportunity for us to innovate, opportunity for us to take better care of the patients. So poor outcomes for about 3/4 of patients with MCA or intracranial ICA occlusions. All right. Now, just real briefly, we're going to take a step back again and look at those deficits. This is probably a review based on what I saw of your prior curriculum, but I mean, these are the things that we're really looking for. So neurologic deficits are going to reflect the area of the brain that are impacted, the severity of that impact, which is also going to define what our intervention might or might not be. So weakness, numbness, tingling, speech problems, vision problems, these are the basic things that we are always on the lookout for. Obviously, real estate is everything. It's location, location, location. And you can have a relatively large volume occlusion in a non-eloquent area, a pretty silent area of the brain that isn't going to make a huge difference unless it swells and causes mass effect. On the other hand, if you get the left frontal operculum, that's bad news bears. They're going to have a high NIH. It could be a relatively small volume stroke, and yet still be devastating. And that's not even to mention what can happen in the posterior fossa, where you have the brainstem nuclei packed very densely. Patients can do extraordinarily poorly with even just one small brainstem perforator that goes out. And, you know, that's not even to speak about sort of what we are yet to understand. So one of my chief residents in residency, Mike Shagru, has been heavily involved in this push towards connectomics, right? So it's not only about real estate, but it's about how real estate talks to other areas, and it's the connections between areas of the brain. And I think this is a fertile ground for innovation and understanding as we can sort of fine tune our understanding of function and relevance, then we would be able to understand better what our interventions might or might not need to be. Okay. So, you know, dominant hemisphere, left side for most people. I'm a lefty, so the dominant hemisphere doesn't apply here. But for most folks, left hemisphere, so right hemiparesis, right hemisensory loss, left gaze, and then visual field aphasia, neglect. Right, that's what you expect with a left-sided lesion. Now, if it's the non-dominant, if it's the right hemisphere, things are a little bit different. Certainly in the lefties, that may be the area where language is located. That being said, even most lefties are going to have language, at least some language, on the left, ipsilateral to their dominant hand. So this can be a little bit of a mixed bag. Just earlier this week, I had a stroke that came in. A patient who was right-handed, had a right ICA occlusion, and was aphasic, right? That didn't make sense. We said, okay, are we missing something? What are we missing? It turned out that she had a left carotid occlusion in the neck that was reconstituted up top. She was getting cross flow across the ACOM, except her thrombus was at the ICA terminus, giving a hypoperfusion because there wasn't enough flow getting across the ACOM. So she had bihemispheric symptoms. So obviously that's somebody who had a really high NIH, 20s, almost 30, I think, with only a non-dominant hemisphere stroke. Now, what can we do about this? Well, there's been a big push to try to innovate in stroke care. This is a picture from out of Germany of one of the stroke mobiles, as it were, where you have a CT scanner in the unit. The idea being, let's see if we can better triage these folks. Let's see if we can better give them thrombolytics. But that's a tough ask, right? I think in Houston there may be two. Houston's a huge city. The conceit that one CT ambulance is going to be able to service that large of an area. This is just, I think, a novelty and not really going to change the way we practice. What is going to change the way we practice is what happens once they get to the hospital, and being able to better deal with preventing disability. So let's talk about what's going on in Buffalo. So why is there a major vascular center in Buffalo? I mean, Buffalo is sort of in the middle of nowhere. It's in the snow belt, and what's going on? This is a sort of the classic heat map of the stroke belt of vascular disease. You can see certainly the South has its fair share, and Buffalo is just up here in the center. Up here in the corner, we've got a little bit of a hot spot. But really what makes Buffalo great are the chicken wings. And the good news is that the anchor bar, which we're seeing up here in the corner, which is the place where the Buffalo wing was invented. It's literally right across the street from our emergency room. And there's a secret underground tunnel with a zip line that brings the patients from the chicken wings into the ER and then up to the cath labs. And it's quite frequent that we're pulling chicken wings undigested out of people's carotid arteries. It's a combination of things, of course, but poor diet, long winter, sedentary lifestyle, a lot of bad genetics here. We've got a huge prevalence of vascular disease in this area. And this is, what has developed. So right across the street over here is where that anchor bar is. And this is where I'm sitting right now up in the Jacobs Institute. This is our shop. So we've tried to, we meaning my mentor, Nick Hopkins, tried to innovate care around vascular disease, cerebrovascular disease. And we wanted to vertically sort of integrate all the care, research, and innovation paradigms in one place. And this is what we've got. So the ambulance arrives on the bottom. They do not pass go. They go straight to imaging. They don't go to a room. I'll show you sort of our protocol. And from there, they can come up to the cath labs on the 4th floor, the ORs if they need on the 3rd floor. And then we've got sort of the university and innovation space above that. This is sort of a roadmap of what happens once somebody arrives with stroke symptoms. We've got 2 parallel teams that are activated. There are a few different ways that stroke systems work, at least in this country. Often, and I work in one of the other stroke systems as well as this one, the Kaleida Health system. In the other system, everything goes through the neurologist. So it's not parallel processing, it's serial processing. So often it's the neurosurgeon doesn't know anything about the stroke until the neurologist has evaluated, and then they will call and say, hey, will you evaluate? I think this is something. Problem there is, number one, there's sort of a filtering that's happening, and number 2, there's a delay. What's happening at Gates Vascular is that we have parallel processing. So the patient comes in, get basic labs on their way to the scanner, don't stop and get a room. Both the vascular neurology and the vascular neurosurgery teams are activated. And in parallel, our fellows are competing to do the NIH stroke scale down there in the emergency room, trying to independently figure out, do they need TPA, do they need thrombectomy, do they need none of the above, right? And what that means is that we're able to expedite. We've actually just installed a new scanner in our ED facility that's essentially the CT study that's going to do all this stuff, plus the cath lab all in one, right? So if the patient looks like they've got a large vessel occlusion, you don't transfer them up to the cath lab anymore. You bring in the C-arm, the nurse puts a drape on them, and we start the thrombectomy right then and there, really expediting that care, okay? Now, imaging is a huge part of trying to figure out what's going on. Obviously, not all stroke is stroke. You've got seizures, you've got hypoglycemia, could be hemorrhagic, could be ischemic. And so this is sort of the protocol that we get on every patient that comes in with neurologic deficit. Starts with a non-contrast head CT, and then they get a perfusion and a CTA. Looking for vascular lesions, be they hemorrhagic or ischemic, looking for the functional status of the brain with that perfusion. And then down the road, we'll get MR and Doppler and so forth after something has happened. The non-contrast CT obviously is important for that first sort of branch point, which is bleed, no bleed. If there's no bleed, almost certainly the neurologists are going to want to give TPA. We've got pretty aggressive neurologists, so they give TPA even sort of outside of guidelines, because we're believers that if you don't open it up, they're not going to get better, and we're going to have problems. But the CT can also give us some other information. We can look at hyperdense signs. So if the vessel lights up, even without contrast, that gives us a sense that there's clot there. If, on the other hand, we see that that territory is already hypodense, that the parenchyma is already dark, that gives us a sense that we've got completed stroke, and maybe we ought to be careful about reperfusing that area. So a few different things that we get from that. We then proceed directly into the CTA. And I think an important key here is we want to see all the way from arch to vertex, okay? We want to see all the way up. And in fact, we're kind of extending that protocol to see the heart. It looks like early data suggests that with some cardiac gated imaging, we're able to actually see thrombus in the heart, in the atrium, in for instance, atrial fib patients. And that tells us a little bit about something that we might need to do down the road to prevent another stroke, but also the likely composition of the clot and what devices might be useful for retrieving that clot. So we're going to get arch to vertex, get a look at sort of all four of the vessels going to feed the brain, the two carotids, two vertebrals, as well as sort of the intracranial space. It's going to give us what we call a poor man's angiogram, a 4D CTA, where you can watch the bolus wash through from arterial to capillary to venous phase. This is great for looking for AV shunting. So in the case of ischemic stroke, you will often see there's not going to be any oxygen extraction by the capillary bed. And so it'll go directly from arterial to venous phase. And that early shunting is a sign of dead brain. In the hemorrhagic sense of things, you're able to see AVMs, AV fistulas. You can see sort of that spot sign where you have bleeding. So this is really an important study. And of course, it'll give you an idea of morphology. You can pick out your aneurysms. You can look at your large vessel occlusions. You can understand what the geometry of your vessels is going to be so that you know how best to plan your intervention. And then this is a slide looking at sort of what that perfusion imaging looks like. There are a few different, so obviously a lot of different parameters that you can draw out that can be helpful. But sort of my simplistic brain, the way I think about this, top right is my time to peak. This tells me how long it takes for that bolus to get through the various areas of the brain. Red means brain's on fire. That's the area that's at risk. And then you can either look at cerebral blood volume, CBV, or CBF down here in the lower left. I'm a CBV kind of guy. And what I'm looking for is infarcted core. So if there's a black hole, that tells me that that's already too far gone, okay? With some caveats, but too far gone. And so if we match up our time to peak with our CBV, if more than a third of the territory is already infarcted, very likely we're gonna say this is a no-go. Now, lots of caveats there. There's increasingly data suggesting that although perfusion was critical in getting the initial stroke trials through, now maybe we're excluding too many patients. Maybe we need to go after those with even dead brain that you can make them better. So there are clinical trials ongoing. This is a young field. There's a lot of innovation here in terms of answering the questions of how best to treat these folks. So this is what we're looking for, obviously. Ischemic stroke, we're strangulating the brain, clogs either proximally in the cervical carotid or more distally in the distal vasculature. And this is what that perfusion map is really looking to help us to understand. So in black, that black hole, that's the infarcted core, that's dead tissue. The surrounding penumbra is going to be, of course, the brain that's still on the fence. Is it going to tip over to survive, or is it going to tip towards dying? And that's the area that is at risk, and therefore that we want to ideally save and reverse the ischemia, restore the function. Okay, time is of the essence. We all know that, but this is that ischemic penumbra is really where that time becomes critical. Okay, so the goals of acute ischemic stroke treatment: restore the blood flow to the salvageable brain, reduce the non-salvageable volume, and ultimately we know that this is going to improve clinical outcomes if you're able to do that effectively. So let's look at sort of the reality of treatment, sort of in the U.S. and here. So across the U.S., IV TPA rates since recombinant TPA was FDA approved in 1996, about 3 to 4%, which is pretty abysmal in my mind. A lot of it is because of the very stringent trial criteria to get it approved. Those are the criteria by which neurologists are evaluating, and many neurologists are much less sort of willy-nilly gung-ho than their neurosurgery counterparts. I often say if they put TPA in the hands of the neurosurgeon, everybody would be getting it. And currently, endovascular options, although this is a changing statistic, very small proportion, right? Only about 1% are getting any kind of endovascular option. here, at least these data are a few years old, but we get about 2,000, 2,500 stroke evaluations per year at GVI, about 5% getting TPA, and probably about 10%, about 200 stroke interventions per year. And then that often feeds our carotid practice, so about 200, 250 carotid endarterectomies and stents per year. Okay, so obviously what really matters here is the clinical outcome. And so this is really what we're striving to get. I'm going to skip over a few of these things, and we're going to jump ahead to some of the management stuff. So excuse me while I'm jumping ahead here. So let's talk about, so we talked about how TPA is really a problem in the sense that not many folks get it. It does lead to increased bleeding and doesn't work for larger vessels, okay? Maybe that's an important slide that I should put up here. This is the efficacy of TPA by location, which location is a surrogate for size. So distal MCA occlusions works pretty well. About 33% of MCA occlusions will open up with just IV TPA. So come more proximal down to like either an ICAT or a carotid occlusion. Carotid occlusion, 0%. IV TPA will not open things up, and in my mind, therefore you shouldn't give it because it's going to inhibit my ability to be aggressive with opening things up. So it's only potentially a detriment in a carotid. It is potentially beneficial when you're more distal MCA, even distal MCA and so forth. Okay, so TPA has differential efficacy depending on the site of the occlusion. All right. So let's look now at sort of what those endovascular options are. Obviously, we needed to be able to do something to open it up directly and in a time-effective manner, and there were a number of trials that did that. And in particular, in 2015, there were a spate of trials that sort of broke through and showed this efficacy. There were several trials that happened beforehand that were negative. We learned from those, redesigned trials, and then came out with these other trials that ultimately proved it to be efficacious and have driven sort of a sea change in terms of how we deal with this disease, right? This is really a paradigm shift for management of stroke. And so what happened? Well, what happened is that we developed new technologies that were more effective, and in particular the stent retriever. The solitaire, for instance, that was the device of choice for the SWIFT Prime trial, was really something that was a game changer. So this was born of an idea. You know, there in the good old days, we had this stent that we would use for stent-assisted coiling. There was a stent on a stick that you could detach it once you had placed it. And somebody had the bright idea, well, what if we just don't detach it? Let's use this stent on a stick and let's see if it'll pull things out. Of course, that worked. And the sort of a whole new device category was born. So this is, I'm sure many of you have sort of seen, let's see if I can actually make this play. That would be great. I guess this isn't the video. But the way this works, as many of you have probably seen, is you navigate your micro system across the clot. You can then unsheath the stent in the clot, and the stent becomes entangled, or the clot becomes entangled in the stent. You can then pull it out and hopefully therefore restore blood flow. These are the gratuitous clot shots that everybody loves after these kind of things. Lets you know that you did something good today. And hopefully you get good flow as a result of it. This is the New England Journal article that followed this with Prime trial that demonstrated that efficacy. You can see here what we call a modified Rankin shift analysis, where we can see that we are going from the higher MRS, modified Rankin scores of death and disability, to lower ones for those that get, so you have more folks in the lower end of the strata as a result of endovascular therapy. And this is really done without significant side effects, right? The operators in the trial did a great job. Symptomatic intracranial hemorrhage did not exist in this category. Now, that's not to say it doesn't exist in real practice, but it was even lower than TPA in the case of this trial. And these results, as noted here, have really placed endovascular at the forefront of strokes treatment and redefined the standard of care for ischemic stroke. Okay. So this is really where the state of the art stands, in the sense that we really have to go after these strokes. What we know is that this is also shifting over time. So it used to be, so we grade a reperfusion on the TICI scale, 3 being complete, and then 2 having a range from 0 to 50, 50 plus, and then slow flow. We're getting more and more picky. We're requiring higher rates of revascularization for good results. And it's just a result of better devices, better selection, better technique, and really this is a field that's vastly improved. So let's walk through one of these procedures. See if I can get this to play. If any of you have questions, by all means, feel free to interrupt. So this is a patient who came in with an NH stroke scale of 9, so only moderate, but you can see here the carotids and basilar and back is what's missing. You don't see that posterior circulation. We see increased time to peak in that posterior circulation territory. We've got a basilar occlusion. So here we're going to go transradial. We're going to come up the arm as opposed to the traditional transfemoral approach, because that gives us more direct access to that posterior circulation. So coming in the left arm, going up the left vertebral artery, you can see that injection, and it just really doesn't go anywhere once it gets to the head. The other thing you'll notice, the patient's moving. This is an awake patient. That's how we like to do things here, to make it a little bit more challenging. But what you can see is that right where at the VBJ, where the 2 vertebral arteries come together, we don't have any distal flow. You've got a mid-basilar occlusion. This is a death sentence, right? Even though the patient is currently only in an age of 9, it's only a matter of time. So in this case, we're going to use what's called an adapt technique, where we go in with a large bore aspiration catheter, really kind of cork the clot, engage it at its proximal surface, apply a suction pump, and then we are able to sort of remove it. You can see the patient shaking their head, no, 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 it hurts a little bit, but that is sort of a sign that we're doing the right thing. We're actually pulling something out. And once we're able to pull it out, this is going to be our follow-up run. You can see that we've got full revascularization of the vertebrobasilar tree, and we can see that the patient is going to do much better as a result of that. Here's that gratuitous clot shot. Here's our thrombus that we pull out. The patient did have some dysarthria, but ultimately was discharged home in very short order. All right. So that is the satisfaction that comes with thrombectomy, right? This is not what most neurosurgeons got into neurosurgery to do, but this is genuinely the most satisfying part of my job, because this is where we're actually helping people, as opposed to, you know, making them actually feel worse in the short term and just preventing future problems like we do with aneurysm surgery and things like that. So there's still some opportunity for innovation here. This is, you know, there are ongoing studies in terms of trying to extend the window, as it were, looking at pediatrics, looking at a brain that appears to already be dead, that may actually be salvageable. Distal occlusions going around from M1 up to M3s and 4s. And of course, any number of other new devices that are out there. I'm just going to show you another stroke case real quick here. And this is a relatively recent one. So 43-year-old woman, mother of 2, multiple DVTs during pregnancy, was on Coumadin, had been taken off Coumadin for some other testing. And I think because the patient also had a history of cerebral aneurysms, once they found that out, they got nervous and took her off the Coumadin. Of course, the patient shows up in the ER unresponsive, NH of 31, so very severe stroke. Bilateral extremities are flaccid, no reflexive eye movement. This is only brainstem reflexes and extensor posturing. So severely obtunded. This is bad news. So this is what that looks like. Again, we can see here our carotid's coming up anteriorly on both sides, but then our basilar comes up and we're missing a little chunk out of the top. This is the top of basilar occlusion. This is where our thrombus is. You know, this patient is suffering because of it. Now, according to sort of everything that that we know from the literature, this is mortality rate of 85 to 95%. This patient's out of the window. So are you going to be the one that tells them, I'm sorry, mommy's not coming home? You know, and the answer is no, we have better options. This is what we can do because of these advances that have been made. So we can see here on the right, that basilar artery, we can see the chunk out of the top, and you can see that we've got our aspiration catheter up into the left P1, sort of corking that thrombus. Let me just see if I can play this video for you here of the run. So that's what it looks like. You can see that we've got no flow at the top of basilar. That's where all those thalamo perforators are. That's why she's obtunded, because she's not got no flow to her bilateral thalami. So with that, that aspiration catheter corked, we're able to pull out the clot and restore flow in, you know, a single pass, 9 minutes from, in this case, groin to revascularization. And here you can see that there's a very mild DWI spot, a little bit of stroke, but the patient does remarkably well. So stroke workup reveals a patent foramen ovale. The patient gets the anticoagulation restarted, closes the PFO, post-op day 2, patient goes home, neurologically intact, okay? So this is sort of this is why this is such a satisfying thing. This is not an elderly patient on her way out the door. This is a young mother, vibrant, and we gave her and her family their lives back, right? It's a tremendous opportunity to impact people and really to impact at a population health kind of level, okay? So, so that's sort of the ischemic stroke part of things, the thrombectomy and treating it. Now, there are some other things that come along with that, and we'll just go into a few different things that we run into apart from just sort of the typical thrombus. Of course, as part of the secondary stroke workup, we're going to find a lot of these things. The most common causes of the stroke are going to be things like arterial to arterial embolus, like a carotid, so large artery stenoses. Dissection is one sort of subtype of this, where you've got a tear in the vessel. You're going to look at the cardiac status, or is there atrial fibrillation, a thrombus there, an atrial appendage, looking for hematologic factors, a factor V Leiden or whatever it might be, clots in the veins, PFOs. That's part of the secondary stroke workup, and that's where we can also get involved with some of our things. So looking at the dissection, this is sort of a pretty common thing, especially in young folks. Young women, especially in their 20s, you know, sudden neck pain, often that can be a sign of dissection, or even young men working out, heavy lifting, this sudden sort of onset neck pain. And that pain is sort of a tearing of the lining of the vessel. So you, as you recall, you've got the 3 layers of the arterial wall, intima media adventitia. If you have a separation of those layers and your intima becomes separated from the other 2 layers, that can become a little flap. And if it's pointing the wrong direction, the anterograde flow of blood is going to pin that flap against the wall, okay? So there are a couple of things that can happen. You can actually suffer a complete occlusion because it's pinned against the wall and it's obstructing flow, or you have sort of that intima hanging in the breeze, flapping like a flag, and that becomes a nidus for thrombus. You've exposed the basement membrane, it's thrombogenic, it's creating turbulent flow. That can cause a little emboli to shoot up as well, okay? So a couple of different ways that these dissections or tears can cause problems. Okay. Now the internal carotid artery dissection is relatively rare, only about 2.5% of strokes, but these are ones where we end up spending an inordinate amount of time dealing with them because they can be quite difficult. Nearly 25% of ischemic strokes in patients less than 40 are from dissections, and so again, this is a disease of young folks. Patients can also get intracranial dissections, which are particularly dangerous because you don't have the thick media in the intracranial vessels, right? So you don't have that thick muscular layer. And so if you have a dissection, those can easily change from just an ischemic problem to rupture, hemorrhage, hemorrhagic problem. Okay. And then extracranial carotid dissections, that's a very common thing that we'll see, especially in our trauma centers. You get in a car accident, the sudden acceleration, deceleration can cause a lot of these tears to happen. Okay. Symptoms are largely sort of the same kinds of things we would see in terms of the neurologic dysfunction, depending on if it's throwing off clots. But then we've got sort of the tearing neck pain, often if it's in a vertebral, an occipital headache sort of thing that can happen, even extending over the top. Very, very common. If you look down here, we've even got sort of the Horner syndrome, where you've got the ptosis, meiosis, anhidrosis. That's because you've got sympathetic chain that's traveling up the carotid. So a dissection in the carotid can actually lead to a Horner syndrome. That's sometimes the way we pick up these dissections. So a lot of different things that can happen to bring this to our attention. You can see here the associated clinical findings in the picture. You've got sort of the seatbelt sign. Somebody comes up against the seatbelt in a rapid deceleration. That can be something that goes along with this dissection that we often will see. Cranial neuropathies are possible with these dissections. Often there'll be a cervical bruit. Again, we're going from laminar flow, smooth flow, to turbulent flow. And that's something that you can hear. Now, neurosurgeons don't know what stethoscopes are, but the ER doc may find it for you and say, hey, I hear something in the neck. I think we ought to check that out. It's valid. It's real. Okay. So those are some of the clinical findings that we will see with these. Now, in significant trauma, epistaxis, so nose bleeding, is another thing that can go along with this. Again, significant injury to the extracranial external vessels is what we're seeing there. There are a number of conditions that predispose to this, things like collagen vascular disease, Ehlers-Danlos type 4, in particular fibromuscular dysplasia, Marfan syndrome. These are some of the very common things that we that are associated with dissections, make it more likely, and that impact our ability to render certain kinds of treatments. So in folks with really severe collagen vascular disease, like an Ehlers-Danlos type 4, we don't want to put a catheter anywhere near them. This is going to just make things worse. So some of these things are worth knowing about should they be found. The way we evaluate this, so everybody, as I mentioned, gets a CTA, CTP. That's useful for sort of anatomic information. But really, the best is going to be what we call an MRA dissection protocol. It's a T2 fat sat. And what it allows you to see is the wall of the vessel. And you're looking for intramural thrombus that can be a sign that you've got that dissection, that separation of the 3 layers, thrombus in between. And that's really the telltale sign that dissection is your problem, as opposed to some kind of other clot or obstructive etiology. Okay, this is what that looks like. I'll just point out left carotid. Let's see if I can find my pointer. You can see this bright crescentic shape. That's going to be the intramural thrombus. Okay, Doppler can also be quite useful. You'll be able to see a separation between false lumen and true lumen with the flap in between. That's that separation. Can be quite useful, especially in the extracranial carotid in the ICA if you're trying to evaluate these things. Okay. So determining the cause of the dissection is important. This is a little bit of sort of a Denver criteria for blunt cerebrovascular injury. Looking at the various severities from 1 to 5, with the 5 being a complete transection. That's pretty rare. A little bit of irregularity is pretty common. And depending on the severity, you've got different treatments, anything from an aspirin to prevent clots from forming to needing to actually revascularize or replumb the thing. Okay. So surgery and bypass, really before these used to be the mainstays. Now these have been relegated to a much less prominent role. I saw a hand raised. I don't know what to do with that. Go ahead and speak up if you got a question. No?
Let me see. I think I have to unmute the person.
Oh my.
I'm not seeing the hand
Okay.
raised.
Or you
If
can
not,
put it in
maybe
the
put it chat.
Q&A.
Yeah.
Yeah. All right. So endovascular therapy is really where we see most of the management of dissection going now, where if you've got flow limitation, hemodynamic compromise, then we can use a stent to try to pin that up against the wall, restore the flow. Otherwise, first line is antiplatelets. So aspirin is usually all it takes. All right, prognosis is good. Usually these things heal. That's the good news. The bad news is that the pain doesn't go away, right? So we aren't treating these folks because of the pain. The pain is a sign that it happened and it's going to go away on its own, but it takes time. And these patients are miserable. They're calling back. They don't like it. Unfortunately, there's not much we can do about the pain. Okay. The endovascular management, we've got a number of different devices that we're using these days, a lot of different ways of going about the revascularization, but more or less it's about stenting, right? So use that mesh tube to hold things open, and you want to be able to do it safely. And so we've got adjunctive devices where we're able to either reverse the flow so that you don't have, so you can imagine you've got a flap that's pinning up against the wall. Anterior grade flow is just forcing it closed. You can put up a balloon, reverse the flow, apply suction force, and that's going to open things up so you get flow over the top through the circle of bolus and down. Things like that are going to protect you from any distal emboli and potentially make it easier to revascularize. You can see here what that looks like when you have stents to hold things open. That's probably the main thing that we are going to see. And sort of the telltale sign of this, I'll just show you right here. You can see sort of that dissection flap. You see some widening of the vessel. That's a pseudoaneurysm. And once you place your stent, that's going to close down the flap, allow the pseudoaneurysm to heal over time. Right. So let's look at a couple of cases now. So 46-year-old history of vertebral artery dissection. Had a recent right spontaneous carotid artery dissection, presented with worsening headaches, multiple TIAs impacting the right hemisphere. So right carotid, right hemisphere. Past medical is significant for that prior vert dissection. So we're suspecting there's some kind of a connective tissue disorder, headaches, hypertension. Patient is currently on aspirin, Brilinta, and enalapril. Currently neurologically well, but obviously something's going on. We're having these recurrent TIAs. So these are the devices. I won't belabor the point, but the idea here is we're going to go in and we're going to try to revascularize this. So let's look at this. This is the right common carotid artery injection. So a lot of spaghetti, but let me walk you through what it is that we are seeing. So let's see if we've got a video here. So this is that injection, and what we're seeing here on the lateral, you've got the carotid, the common coming up, external coming forward. Obviously, external is the one with the branches on the neck. The internal doesn't have any branches. This right here is the carotid bulb. We can see a little bit of a dilatation in the internal. That's normal. That's not the problem. The problem is up here where we've got a dilatation right near the skull base. You can see, I'm just going to play that again for you, that you've got some turbulent flow. There's a little bit of stasis of flow in there. And you've got a little flap that you can see sort of over the top right there. On the AP, you can see again the top right there. And you go from sort of a normal looking vessel to a massive dilatation. That's that pseudoaneurysm in the dissected segment. So we've got to reconstruct this. In this case, we're going to do it with a peripheral vascular stent. So we put our guide up. We're going to, and the trick with these is always to get into the true lumen. You don't want to get into the false lumen and extend the dissection, push things north. So you've got to somehow navigate from true lumen to true lumen, make sure that you are there. sort of you've got to get to true lumen before you get to the ophthalmic segment, before the carotid artery becomes intracranial, right? Once it's intracranial and it's in the subarachnoid space, if you accidentally pop through, you have subarachnoid hemorrhage, you have death, right? You can pop in and out of dissection planes before you get there, even in the cavernous segment, and the worst that's going to happen is you cause a CC fistula. We can treat that. The patient's not going to die. But once it gets up into the intracranial space, game over, we're done, okay? So we've got to find that true lumen before we get up to the ophthalmic segment. That's the long and short of it. So here we've got our guide, we've got an intermediate. We're going to try to get a high resolution picture to find that plane and get from true lumen to true lumen. Let's look at those runs. So we'll see here a run, and you've got the normal vessel. You see the pseudoaneurysm, and we're going to use that as our roadmap. You can see on the lateral a bit of that dissection flap. We'll use that to be able to try to navigate our wire. And again, we just have to go very gingerly and really just try to feel your way in with the wire so you don't accidentally get into the wrong place. And a lot of this is based on feel and based on vision. If you see the wire buckling, if it's bending over, that probably means that you're pushing up against something and you don't want to continue that, or you're going to cause things to get worse. And then just feeling if it's twizzling freely in the lumen or not. Let me just advance this a little bit. You can see that we've got the wire beyond it. We've got the wire in the horizontal petrous here, and actually up into the posterior cavernous segment. And what we're able to do at this point is to bring up our stent now. And with our wire across it, we can get the stent up and really kind of plaster it against the wall, open things up, and occlude that pseudoaneurysm. Now, this is a problem area for devices. We don't have the perfect device for this. This is one that we were using about 3 years ago that we thought was okay. There's some problems with it, but in the end, in this case, it's going to do the job for us. I'm just fast forwarding to show you what that looks like. Now we've got a stent in, we've got our wire beyond here. We're bringing up our stent actually here. And the problem is there are lots of twists and turns in the head that don't exist in other areas of the body. So we try to borrow devices from cardiac, from peripheral vascular, but our vessels are twistier, turnier, and they are thinner. And the combination of those two make it very difficult sometimes to get around the bend and to deploy. We're going to see here that we're going to ratchet the device open, and you'll see it kind of popping open here as it goes. We're trying to keep the wire from going intracranial, and we've got our stent now in place. You can kind of see the tines of it, hopefully. And we're just trying to really work it back and forth to be able to cover that pseudoaneurysm and make its way around the corner. Here, we're just massaging the stent. Ultimately, we're able to get it open, bringing that nose cone of the stent back, and that's going to allow us to complete our deployment. Let's go a little further. Now our stent's completely open. Our follow-up run here, you can see there's some filling in that extraluminal space in that dissection in the pseudoaneurysm, but it's really quite static. And what's going to happen to that over time is it's going to clot off. It's a blind sac now. It's not in the main course of flow, and this is going to heal beautifully. Usually after about a month, the pseudoaneurysm's gone, and the stent will heal in nicely. So that's exactly what we want to see in this kind of a case. Now opening that true lumen, preventing any clots from traveling north, and certainly preventing it from flapping shut and occluding up to the brain. So that's kind of what one of these cases look like. These are very difficult. Often we end up kind of with a full metal jacket from top to bottom. You know, not uncommon to have $50,000 worth of stents after a dissection case in the patient, because it's just, they can be very difficult to reestablish flow. This is the follow-up still shot. And in this case, patient neurologically intact. They do quite well with these if you get to it before it causes a major stroke. In this case, going home post-op day 1. Okay. Here's another case that I'll show you.
Dr. Davies, if I can just stop you, there was a question on that last case about kind of the nuances of properly finding the true lumen. I know you mentioned there was high resolution imaging. If you can just highlight that.
Yeah, so flow reversal is one thing that we really like to do. So we've taken to using balloon guides for most of these cases. So my common setup for most cases is we'll go transradially with what's called a walrus. It's an 8 French balloon guide system. You put it up and occlude flow, inflate the balloon, and put it on suction. That flap that's now open is going to shut, and you get the blood flow coming back over the circle of Willis. In that case, it makes it pretty easy to navigate the wire across it because you're sucking the flap back. The other thing that's crucial is you want to navigate with a microcatheter. Once you're across the area that you suspect is the dissection, wire comes out, microcatheter injection, make sure you are in true lumen. You want to puff and you want to see that the MCA candelabra, for instance, lights up. If it doesn't, if it's a blind pouch, you're in the wrong place and you got to try again. There are some newer techniques that I think are developing where you can actually cross through a dissection flap. In the coronary space, they do this all the time where they will cross dissection flaps in the subintimal space. We are nervous about doing that in the head for good reason, but I think there may be a role for it, especially in extracranial carotid dissections. But really, it's about trying to get the right view to be able to see a plane, and then just you twizzle the wire and try to find it as best you can, and then verify once you're across. There's no magic bullet. This can take a long time, a lot of fiddle factor, a lot of futzing to get it to work.
Awesome. Thank you.
Okay. All right. Another young patient, another trauma, 34-year-old woman had a fall on a high ropes course while harnessed about 30 feet off the ground. Afterwards, the patient had some neck pain, left-sided weakness, slurred speech, NH stroke scale. Actually, this is one that progressed over time to become quadriparesis, requiring intubation ventilation, so very high stroke scale. CT demonstrated no hemorrhage. Patient was out of the window for TPA. On arrival, patient's paralyzed, intubated, sedated. Okay, that's what we get. In this case, the patient had a left angiogram that demonstrated stasis of flow. That's common. We aren't seeing anything going north. And we know that there's a trauma history young patient. This is going to be a dissection every time. Okay. This is what we see when we do get a glimpse of the basilar. You can see sort of that fluffy cotton wool appearance. That's going to be clot within the basilar. So massive basilar thrombus because we don't have good anterior grade flow. So the plan here is we need to repair the vert dissection. We need to open up the basilar and aspirate the clot. Okay. So this is what that looks like. You can see here the guides in the distal V2 segment. We're going around the C1 arch, and then as it's going intracranially, you lose your flow. Just a trickle of flow going through. So we navigate around that, just kind of feeling your way through. And then once we get across it, this is our microcatheter injection, verify that you are intraluminal. And you can see that we still have some clot there, but at least we know we're in the right plane. Once we're in the right plane, we're going to see here that we're deploying a stent. These are the distal stent times coming back, and we're going to plaster that dissection open. And hopefully give ourselves a channel to be able to get our additional catheters up to do that now a basilar thrombectomy. In this case, multiple stents, 3 stents deployed around all of that tortuosity, and ultimately we're able to get in with multiple stents. And now we are up to the basilar. You can see here what that reconstruction looks like. You can see sort of that dissected flap here. You can see the extraluminal component. And in this case, if I have a picture like this, getting at our last question, I'm going to hug the wall over here of the vessel with my wire tip so that I avoid the left side, go on the right side where I suspect the true lumen is. And then you're twizzling, you want to see that the wire tip is moving freely. If you're going around in a spiral, that's what we call a spiral dissection. It's just going around the intima, and you're not in the true lumen here. So a number of sort of little tricks to make sure that you're getting into the true lumen, but ultimately there's a lot of luck and hard work to try to get it. So this is what it looks like. You can see it's not a perfect reconstruction of the basilar, but by post-op day 7 we have a really good reconstitution, and you can see that the MRI brain demonstrates some basilar occlusion. But ultimately, the patient's gonna make it through this and hopefully go on to recover. All right. So we're coming up at the 1 hour mark. I'm gonna skip over some of this data science stuff. I'm happy to answer any data science, but we've been working to try to have better machine learning tools to be able to predict vascular outcomes and that read some papers. It's fun stuff. Now, let me just close up this part of it with sort of what do I see for the future? So better devices. There are a whole slew of new devices on the market, different approaches for opening these things up with the goal of it being more reliable, faster, first pass every time. Better identification of who ought to go for thrombectomy. And it's probably more people than we think. To give you sort of a statistic here, so in the SWIFT Prime trial, the number needed to treat to save 1 life was 4, okay? For comparison, in the STEMI trials, the number needed to treat was like 8. So this is way more effective than thrombectomy for STEMI or stenting for STEMI. And that probably means that we're excluding too many people. So we need to relax our criteria, include more people, and figure out, I think, not who should go for a thrombectomy, but who should not go for a thrombectomy. And the default should be, let's activate, let's get it going. We need to pull the clot out. Okay. There's a lot of work on the drug device interface side of things, looking at neuroprotective agents, and then of course the optimization of workflow that we were kind of talking about. So with that, that's the ischemic stroke side of things. We're going to move on to some more hemorrhagic things. Any questions about that? All right, here we go. What do we think about artificial intelligence as a tool to identify stroke, number 1? And then number 2, is there anything you know about the difference between fast and slow progressors? So let's take AI. So I think that AI is going to be a powerful tool for identifying not only stroke, but who needs to go. So there are currently FDA approved AI algorithms on the market through Rapid and Viz AI to identify stroke. So identify LVO, identify perfusion deficits. That's out there and it's great. My phone, it goes off, every 20 minutes with it automatically identifying these things and alerting me so that we can activate and evaluate. That's huge, and huge for a number of reasons. It works and it is improving patient outcomes. What I'm interested in is what can we do to be able to figure out who's going to get better and who's not? Can we have an intelligent NIH stroke scale? Can we figure out when to stop doing your thrombectomy? Is it worth chasing that M3 clot, or is it only conferring risk and no potential reward? So we're working on that front. I just got an NIH grant, and we've got some others in process to be able to use sort of quantitative angiography, what we call angiographic parametric imaging, to be able to help us in some of these things. We've spun out a new company to try to commercialize some of those algorithms. I think there's a lot of promise there. I'm biased, but I think there are very few things that machine learning isn't going to help in the end. Okay. Fast progressors versus slow progressors. Yeah, so that's a big issue. And when I was mentioning the perfusion imaging having some caveats, that's one of the big ones, right? So the advantage of perfusion imaging is it gives you an idea of the functional status of the brain, but it isn't accurate within the first probably 3 to 6 hours, okay? So within 3 to 6 hours, I think everybody should go, pretty much. After 6 hours, it becomes useful because we'll have patients that come in at 72 hours out, and by any metric, they're outside of trial criteria, right? But if there's still salvageable brain, we ought to take it. And so I think functional imaging, the perfusion imaging, can really help us to identify those real outliers. In terms of being able to tell from that initial CT of the head, the baseline CT, that's, I think, also an area where AI is going to help us. Can we have the algorithms trained to identify the fast versus slow? Can we take into account the other clinical factors? I think the long and short of it is we should open up pretty much everybody. Some people are going to do well, some people are not. There's a philosophy, practitioners are going to have different philosophies. My philosophy is nobody wants to live with an NH of 14, right? Make me a 0 or make me a 40, right? But I don't want to live as a 14. And so I would say go for the thrombectomy. And most people, if they've got middle range NH stroke scales, those are debilitating, and we can make most of those folks better. Okay. All right. What kind of things are being done in the post-stroke hospitalization side of things to improve functional recovery? So this is another area. So I had a prior KL2 award grant to look at predicting who's going to get better. So post-stroke recovery. Right now, we give very generic advice. We say, okay, some people get better quickly, some people get better slowly, some people don't get better at all, but I can't tell you which one you are, right? We're gonna have the physical speech and occupational therapist work with you. They're gonna tell us what works, what doesn't work, and then we're gonna get you to rehab. And then you're gonna try hard for a year, and after a year, we're gonna say, well, I guess that's all you've got. That's about the state of things right now. And of course, insurance doesn't always go along with that. They're not gonna do rehab for a full year. And so, I think there are probably some missed windows of opportunity for patients as a result of it. So we need to be able to better predict that functional recovery. There are some new devices. Eric Luthart at WashU recently had a device approved that shows great promise in terms of being able to improve functional recovery. I think there are going to be any number of rehab devices that do that. Eddie Cheng, my old buddy from UCSF, the new chairman there, just had an amazing paper that came out last week where they implanted electrodes in a patient who was aphasic for 20 years, and we can decode the brain waves and produce speech. The patient can have a normal conversation 20 years after having never spoken as a result of it. Amazing things are going to be done, both in terms of augmenting the functional recovery as well as accommodating those deficits and giving the patients more of a normal life. Role of thrombectomy and expected malignant infarct. You've got little to lose. If they've already lost the hemisphere, if you don't already see bleeding there, there may be a role for it. My partner Adnan Siddiqui just had a case earlier last week, actually. So when we think malignant infarct, we're thinking hypodense on the CT. It looks like that brain's already cooked, nothing you can do. Well, he did a thrombectomy on a patient. They went on over the course of the next couple of days to develop hypodensity in that hemisphere. The thought was, that's cooked brain, we didn't get the job done or whatever, and they're going to go on and need a hemicranie or they're going to swell and die. That reversed itself over the course of about 48 hours. And there is now no hypodensity on the scan, and functionally the patient is like an NH of 1, okay? So expected malignant infarct is very different from completed stroke and proven malignant infarct. I think we open these patients up. Again, nobody wants to live with an NH of 14, make them a 40 or make them a 0. And that's my philosophy. Cutoff for aspects and NHSS for thrombectomy. So aspects, that's an open question. There are active trials, Endolo, Tesla, that are looking to at what's the efficacy of doing thrombectomy in low aspect scores. So patients in whom it looks like the brain's already cooked. And I think promising results. We'll see what the trials show, but I think that low aspects is not a reason to withhold thrombectomy. In terms of NH stroke scale, that's a different question. So current guidelines are 6 or greater in a large vessel occlusion. Is it worth doing a thrombectomy for a 5, a 4, or a 3? I think it depends. I think the natural history is that patients are going to improve a point or two anyhow over time. And so if you're only conferring risk and they would have otherwise a minor deficit, then maybe it's not worth it. On the other hand, if they've got a left hemisphere M1 occlusion and they just happen to be an NH2 right now, but you know they're going to exhaust their collaterals over the course of the next, it always happens at 2 a.m, but they're going to exhaust their collaterals and then go on to have a major stroke, then yeah, I would open up that NH2. So it depends a little bit, but I think those are stories that have yet to be written. Guidelines don't yet support that practice. This is completely off-label stuff. All right. That's 1 hour of me chatting at you. Let's take a 5-minute maybe, and I'll be right back and we'll talk about some hemorrhagic disease. Is that okay?
Sounds good.
All right, take a powder, guys. I'll be right back. All right, so I think the data are showing that ADAPT is probably going to be the right way to go. Some of the new companies that are coming out are looking at ways of getting huge catheters up into the brain. And if you're able to get a catheter that occupies 90% of the M1, very likely you're going to be able to suck that thing out very, very easily. That's number one. Number two, it's a lot cheaper if you only have one device instead of two. And so I think that ADAPT is going to be the right thing for most circumstances. The other thing is when you go around the corner, around the Lehman insula from M1 to M2 out to M3 and 4, when you use a stent retriever, what happens is you end up straightening out the segment, you end up avulsing the perforators, and you get subarachnoid hemorrhage. So I think ADAPT is also gentler on the vessels. And as we push our thrombectomies more distal into the M3s and 4s, I think ADAPT is going to be the right thing to do because aspiration alone is easier on the vessels. All right, so let's dive in a little bit to the hemorrhagic side of things. This is going to be a little bit, shall we say, lighter fare, more videos, some surgery, some endovascular stuff. So hemorrhagic stroke, this is probably not what you guys thought you were signing up for today with the stroke boot camp, but this is the 15%. This is the fun stuff. So here we go. Differential diagnosis, obviously, if you see blood in the head, we're going to be looking for things like fistulas, AVMs. Obviously, aneurysms are fun, but then there are a variety of other things that can also bleed. So trauma, hypertension, tumor, infection, all of these things need to remain in the differential diagnosis. Now, that being said, so let me compare one system versus the other. So one of the systems where I work, they see blood on the head on the initial CT, they stop everything, right? They don't do a CTA, they don't do a CTP. And it's ridiculous because if there's blood, you want to see where it came from, right? Yes, it may just be a hypertensive hemorrhage, but maybe there's an AVM there. Maybe there's an aneurysm there. Maybe there's a tumor there. And giving some contrast with the CTA is going to help you to suss that out. Okay. On the other hand, when they come in at GVI, they get arch to vertex imaging on everybody and perfusion imaging on everybody. And we end up finding a lot of these things. Now let's dive into each of these. We're going to talk a little bit about sort of how we talk about them, and then what we can do about them. So these are pretty rudimentary things, but hopefully it's not too boring. Blister-like outpouching on the side of the blood vessel. Usually it happens at bifurcations. The issue is that you've got the constant force of blood flow pushing up against the wall of the artery. You get a little outpouching, and that can become aneurysmal over time. So surgery. So this is from a lot of these pictures are going to be from Mike Lawton's book, 7 Aneurysms. But this is the basic idea. You want to get in there. And what I always tell the patients is the aneurysm isn't in your brain. It's between the lobes of the brain. And they always are, right? So you want to split apart the arachnoid planes, open up those natural corridors that are created by the vasculature, and use that as your highway to find it, to get down there. So split the arachnoid membranes, follow the arteries, find the aneurysm, and isolate it. The key here when you're doing aneurysm surgery is you really have to know where the safe places to go are. It's very tempting, especially early on. You see an aneurysm and you get target focused. You come down right on the dome of the aneurysm, which is bad because that's likely where it ruptured. And you can run into all sorts of problems. One of the great things about this approach is that that Mike Lawton enunciated is it shows you where the safe places to go are and how best to get there without causing more problems. So stay on the underside of the MCA so you avoid the lenticular striates. Come around the bottom of the aneurysm first, then go to the other side. I mean, these are very practical tips to be able to get these things done. And then, of course, you put your little metal clip on it and exclude the diseased tissue, bring together healthy endothelium against healthy endothelium, and that's where you're going to get the healing. Rates of recurrence after a clipped aneurysm are extraordinarily low because you're bringing together healthy tissue and you're excluding the unhealthy tissue. Now, you can't always do that. Sometimes you need to include some bad tissue simply because you can't otherwise reconstruct the vessel. That's probably an area where endovascular can be used in a hybrid fashion to be able to help us out, flow diversion, things like that, reconstruct the vessel from the inside. Okay. Any number of different techniques for clipping. People often will ask, how do you think you're going to clip this? And my common response is, I have no clue. I'm going to get in there. I'm going to see what the angles are. I'm going to see what kind of corridor I have. And then you troubleshoot. There's not a single perfect clip that's going to reconstruct it. And it doesn't need to be a single perfect clip. Clips are cheap. And there are any number of ways of fashioning them to be able to get the job done. All right. Now, in the vein of clips are cheap, let me show you this one case that I was involved in a number of years ago. This is a very large MCA aneurysm. You can see here M1 coming in, M2 coming out on each side. And you can see the MCA bifurcation is completely involved in the aneurysm. There is not sort of normal vessel with the bifurcation aneurysm. This is abnormal bifurcation. So you've got to get a little bit creative about how you're going to treat this. So this is what that looks like. Let's show you the angiogram. So you can see here that big golf ball left MCA, so high-priced real estate and a really bad problem. This is a surgical disease. Despite all the advances we have in neurovascular, endovascular technology, this is still a surgical disease. You can see here, we've got M1 that we're putting a little temporary clip on. Again, for those who are not aware, gold clips are temporary, less closing force. Silver clips are permanent. Those are the ones that are going to really crush down a little bit harder. So we're putting an M1 clip on to be able to soften the dome of the aneurysm. And then we're going to try to find that one perfect clip placement. You can see M2 coming out over here, another M2 coming out over here. But really, this is just a very large aneurysm, and there are a number of small branches right near the neck. And so I'll just forward through this a little bit. The problem is you try to get that one perfect clip, but we can't find the right plane, getting it to still close. You can see here that there's a perforator that's caught in the neck of in the clip. That's going to lead to a stroke. So that's not going to work. We try to replace the aneurysm clip a little bit lower, try to free it up. Again, that's not going to work. Looking on the backside, you can see that vessel is caught in the clip blades. So now we're going to change strategy. Instead of going in with a single perfect clip that's parallel to the neck, we're going to turn and go perpendicular and do what's called a picket fence clipping technique. So in this case, we're going to place those gold temporary clips on all the inflow, all the outflow. All right. So M2s, M1s, and completely isolate the aneurysm. This is going to dramatically soften the dome of the aneurysm, allow us to manipulate it much more easily. So now the aneurysm is completely isolated, and we're going to come in perpendicular. Instead of reconstructing the aneurysm with the shaft of the blade, we're going to reconstruct the neck with the tips of the blade. So these are fenestrated clips. They allow some additional closing force at those tips to really bring them together. And we're going to place a clip right in the middle and sort of bisect the aneurysm. And now you can see that we are going to stack the clips side by side by side by side. Here, I'll just fast forward through this, but one after another, we're going to reconstruct that neck. And I think we ended up with 17 clips in total. This way we're able to reconstruct that entire neck and bring together that healthy tissue. Now, once we're done, you've got a whole lot of metal in there, and the patient's kind of leaning over to one side because there's so much metal. but we're ultimately able to exclude the aneurysm. And let's just show that's what that new lumen looks like with the aneurysm completely clipped. Okay. So that's one creative way of taking care of it. I'll just show you the post-op CTA. Here's the catheter angiogram. You can see reconstruction of that lumen with all those clips, and then the CTA with just all that metal. So lots of ways of skinning the cat. These giant aneurysms are probably still best treated with open surgery, and so that's what we did here. Now, the biggest issue in treatment of aneurysms is trying to figure out which ones to treat and potentially how best to treat them. This is another area where machine learning and other AI tools are going to help. This is some software that we've been developing in Buffalo that's using CFD, computational fluid dynamics, and now a newer version of this where we're able to do this in real time to be able to understand, is this an aneurysm that's likely to rupture and needs to be clipped? Is this an aneurysm that is low likelihood and shouldn't be treated? Is this a stent coil? Is this a clip? Is this a flow diversion? What's the best way of doing it? And the thought is, let's use the data. There's so much of the angiogram that just gets thrown out the window. You have the surgeon interpreting it, saying, I think this is high risk. I think this is the best way to treat it. But there's so much quantitative data that we could potentially use. And using software like this, we can potentially make that work. Here's an example of this, a paper from a few years ago where they developed a rupture risk calculator using a combination of 3 morphological features and 3 hemodynamic features to be able to assess, is the aneurysm high risk, low risk, intermediate risk, does it need to be treated or not? Okay. So let me show you another interesting case here. So sometimes it's obvious that you ought to treat it and things just don't go quite right. Here we've got a PCOM aneurysm ruptured. Patient comes in with a 3rd nerve palsy. Here I am dissecting out the carotid artery. Aneurysm is going to be somewhere over here. And we're just trying to define the ICA. We pull back a little bit and all of a sudden, boom, intraop rupture, okay? So we come in with that gold temporary clip, place it on the proximal ICA and stop the bleeding. Now we've got a little bit of time. We're going to dissect out. You can see the dome of the aneurysm coming into view over here. And we're looking for the choroidal. The biggest source of morbidity after a PCOM clipping is you accidentally catch the choroidal in your blade. So once I find where choroidal is, I'm able to go in with a permanent clip and place a clip to exclude the aneurysm, stop the bleeding. Okay, we can see that that choroidal is open and free. So that's pretty good. Now we're gonna take our time now that we've got a clip in reasonable position, and we're gonna try to fine tune things. So we've got the temporary clip off. We're now looking to make sure the PCOM's open, make sure that it's like we like it. Unfortunately, in this case, the enemy of good is better. And we decide to add some additional clips to take care of a little dog ear here, a little dog ear there. And the problem is we're going to create some additional problems. All right. So you can see we're putting a little mini clip right at the PCOM. That doesn't sit quite right. So we re-occlude with our temporary clip. And now we've got all sorts of different clips and different configurations going on. And what we're going to see is that although the aneurysm looks good, there's actually going to be some thrombus sitting here in the ICA. Okay. So we've now created a problem because we aren't able to restore complete flow to the ICA. So first maneuver, we're going to open up the clip. We're going to try to flush the thrombus out retrograde, let it come out the dome of the aneurysm that we've already opened up. That's not going to work. So we're going to try to flush the other way. Here, what we're going to do is we're going to isolate it between proximal and distal clips on the ICA. Again, paying attention to that choroidal artery and making sure that we don't occlude that. And here we can try to flush again. In this case, we can frankly open up the dome, go in with some little forceps and try to pull that white clot out, okay? So this is the good old-fashioned surgical thrombectomy. There's a reason this isn't the mainstay of treatment for stroke. It doesn't work very well, okay? So let me just fast forward a little bit. So that doesn't work. So we end up escalating over time. We still have thrombus in the ICA. So now we're going to take off all the various clips that we've put on and start afresh. In this case, we're going to widely open up that neck of the aneurysm, go in with the little nerve hook and try to flush out all the thrombus. Ultimately, that doesn't prove to be very satisfying. And so what we're going to do is escalate again. And now we're going to completely isolate the ICA terminus. Okay, so we've got a proximal clip, supraclinoid ICA, we've got M1 and A1, and we're going to go ahead and do an open thrombectomy. So coming in with our 11 blade, we're splaying open the supraclinoid ICA, little pot scissors to open it up. And what you can see is that there's going to be all sorts of clot in there. You can see all that white clot in there. We're going to take off those aneurysm clips again, really allow us to get a good look, make sure that we get everything out. And here we're able to get all that clot free. And then once we think we have all the clot free, what you do is you're going to open up the clips and really flush it, right? So make sure there's nothing hiding in any of the branch vessels. So you take off your clip and you can see there's a little bit hiding there. You pull it out and you can see frank flow from the MCA. We do that with each of the other vessels, including the ICA. You can see nice robust flow, really flush that out. Once that's done, we go in with an 11-0 stitch, and now we're going to sew shut that arteriotomy and close up that ICA terminus. And I'll just forward through this. This is just gratuitous sewing. And so you can see here, we're just going to shut down, close up that vessel, bring all the arterial walls together. And once we've got that, we can keep playing. Once we're almost done, we want to make sure that we flush it all out. So we tighten up all the loops, leaving the two strands in the middle untied. We flush it one more time, make sure we have all of the clot out, and then we go ahead and tie it shut. Okay. At this point, we've now completely repaired the artery. We can come off with our temporary clips and restore flow to the ICA terminus. We've got now back to our simple single clip on the PCOM aneurysm. And here we're using a Doppler to verify that we've got good flow. We do. All the branch vessels are open. That's our final product. Okay. And you can see here the final angiogram shows good clipping of the aneurysm and good open status of the vessel. Okay. So these are maybe a couple of extreme examples of the surgical management of the disease. Let me show you sort of a more typical management of the disease, which is going to be treatment of a cavernous with good old-fashioned endovascular techniques. So these are really not nearly as sexy, but probably way better in terms of what they do for the patient. And if it were me, I would probably ask for this myself. So 43-year-old male presents with diplopia, left sixth nerve. Father had a ruptured aneurysm, and so this is one that needs to be treated. It's a symptomatic aneurysm. You can see here a pretty large cavernous ICA. Actually, it's probably not even cavernous. You can see the ophthalmic, that's our marker. And so we're going to go in with our, this is a biaxial system, so a guide catheter, microcatheter, synchro 2 wire, and we're going to go up. And here you can see our microcatheter right at the tip and the posterior genu. And we're going to go ahead and cannulate the aneurysm up here under roadmap guidance. You can see here that wire coming up. We're going to come around that anterior bend of the cavernous. We're at the ophthalmic, and that's just going to go straight into the aneurysm. From here, it's a simple coiling. You know, I think coiling is becoming a lost art. It's very easy to do some of the newer techniques with flow diversion and stenting, but this is still a very good technique. And you'll see here that we're able to get really good placement of our catheter, stable position, and that's really going to open the door to be able to create a stable stent construct, or sorry, coil construct. A little bit of maneuvering. I'm just fast forwarding through this, and ultimately we're able to get a nice basket to form within the aneurysm and get a good coil occlusion. So, you know, just a couple of coils. And ultimately, we're able to see that we've got a pretty good repair of that. If you need to, you can come back and add some additional coils later on. You can add a stent later on. but this is going to give a durable solution for the patient. Okay. So that's sort of the mainstay of aneurysm, endovascular aneurysm treatment for the past many years since the advent of the Guglielmi coil. Now let's look at sort of flow diversion. And flow diversion is something that most people are aware of. We're creating a scaffold under which the endothelium can grow and replummet from the inside out. We are also redirecting the flow into the normal course of the vessel. This is going to help us to recreate it. Here's a 51-year-old woman, 3 prior previously coiled aneurysms, and presents for electric treatment of another cave aneurysm. So right where it's at the distal dural ring, you don't really know if it's intradural or extradural. And so this is one that you're going to want to treat to prevent subarachnoid hemorrhage, particularly in somebody who, as you can see, has 3 prior coils there. So in this case, this is a pretty simple procedure for most people, and the better the devices get, the easier this becomes. The nice thing about this is you don't have to actually access the aneurysm. So the hemorrhage risk with this kind of a procedure is significantly lower. The real complications with this come in getting the stent to open. And that's where I say having newer devices really helps, because the easier it opens, the quicker the case, and the less likely you are to have thrombotic complications. So we bring our microcatheter up beyond it, in this case into the M1. At that point, we're able to come up with our pipeline device. And we're really pushing forward, really loading the device in order to try to get some forward pressure and get it to open up. There's a 15 millimeter distal wire, and then the stent begins kind of right here. And you can see that we're starting to unsheath the stent, get it to start to fluff open. And what's going to happen over time is it's going to get good wall apposition there. And we're going to come around the corner into the cavernous segment. And once we think we have the stent in a pretty good position, we can really start to push on it and try to load that stent forward. That's going to compress the size of those cells of that dense mesh and really give us good wall apposition and really exclude the aneurysm around that corner. Here we're kind of going around with our micro catheter, really banging on the walls of the stent, really trying to make sure that it stays open. And then it's up against the walls. Once we've got that, you can see we retrieve our wire. At this point, we do an injection. We see that we've got good apposition, and that more importantly, we have flow stasis within the aneurysm here. That's a sign that this is going to go on to occlude. That's what we want to see. Okay. So treatment of aneurysms, clip versus coil bait is 20 years old. It's no longer very interesting, and I think it's an ever-changing thing. But I think there's a role for both. Okay, endovascular treatment is probably favored in locations that are difficult to access. Posterior circulation is clearly a good place for endovascular treatment. Elderly patients who tolerate craniotomy poorly is another reason to look at it. And for patients who have a poor clinical grade. So putting somebody with a Hunt has 5 bleed through a craniotomy may not be the right thing. You can always at least temporize the aneurysm, and if they get better, you can come back for more definitive treatment down the road. Okay. Surgery is probably favored in those with wide-based aneurysms, particularly in wide-based aneurysms that are ruptured. But again, this is something where technology is really influencing that, and it's changing as the devices change. Those that have vessels coming off the dome, and for those that are severely atherosclerotic or have tortuous approach, that can be problematic for endovascular, and that's probably where surgery comes in. Okay. So that's my brief overview of aneurysms. Number 2 on our differential for the hemorrhagic stroke is going to be CAV-MELs. These are a lot of fun because they tend to occur in interesting locations that require fun approaches. Okay. So, of course, this is the low flow version of a malformation where you have essentially venous sinusoids that tend to leak over time. They leak and stop and leak and stop and leak and stop, and that's what gives them their very typical sort of popcorn appearance on a T2 MRI. Okay. This is a paper that we wrote a couple of years ago talking about how can we safely get to some of these deeper locations using the natural corridors of the brain. So for instance, if you've got a lesion in red, many in the good old days, we would just go transcortical and plow through all this normal brain. Well, there are some better ways of getting there using those natural corridors. This is the contralateral transcallosal and contralateral transcingulate approaches that we wrote about to be able to use that interhemispheric fissure to get to these locations. And that's really going to allow us to be able to go deep, get central into the brain without causing a lot of morbidity and certainly mortality. So this is the view that you get, and I'll show you a video in just a second, but this is kind of the overview. You can see the patient's got the superior sagittal sinus parallel to the floor, nose to the right, and we're splitting the interhemispheric fissure. Using gravity retraction, we're able to drop the lobe of the brain and get all the way down to the corpus callosum without much retraction at all. We can go trans, meaning go across the falx in this case, to be able to get to contralateral lesions without putting the dominant hemisphere at risk, or to go for deep lesions using the ventricular system as a good portion of our approach corridor. So this is what that looks like. So this is a lesion that you can see in the medial thalamus on the right side. You can see it abuts the third ventricle. Here I am splitting the interhemispheric fissure, much like that diagram that I showed you. We've got the pericallosals and the callosal marginals that are coming to view. That bright white that we're seeing at the bottom of the field is the corpus callosum. It's always deeper than you think, but once you get to it, you see that bright white and it's unmistakable. We can then make a little callosotomy, just opening up a little bit of that callosum, 2 to 3 centimeters. And here you're going to see that we enter into the ventricle. Now, question is, which ventricle? Okay. Turns out we're on the other side. We're on the left side. And so not a problem. We can see the choroid plexus diving medially. And so we know that we're on the wrong side. So we just come back and go to the other side. Now we're coming in on the right, the ipsilateral ventricle, and we're coming down to the choroidal fissure. You can see the choroid plexus, we're cauterizing it. And this is going to just help us to shrink it down and minimize any bleeding as we split the choroidal fissure. Here we're splitting right between the fornix and the choroid plexus, and really opening up that foramina Monroe. You can see internal cerebral vein just underneath my scissor, and we're able to get all the way back to the aqueduct and open up and see into the there's our aqueduct there. See into the third ventricle. We're now opening, after verifying with navigation, that medial thalamus, and you can see that we're able to come right in on that cavernous malformation. We're able to dissect that out and really deliver that little mulberry into the field. Here's that gratuitous, and we're taking the cav mal out shot. You can see that that's our little lesion of interest. We kind of flush it out, inspect around, and that's what that looks like. Okay. Fun approaches. Going into the posterior fossa is, brainstem cav mals. We don't have other good options. These are really fun surgeries. All right. How about AVMs? AVMs, I think, as was mentioned, we already maybe had a talk on AVMs, so we'll just show a couple of things, cases here. Of course, this is the high flow variety. So direct connection between artery and vein with an intervening nidus. You're pressurizing the venous system where it's not meant to be pressurized, and that can lead to the bleeding, okay? So classifications help us in terms of understanding risk and in terms of communicating, potentially more importantly. Here's that typical, the classical Spezzo-Martin grade, size, venous drainage, and eloquence, giving us a score to be able to communicate these things. The supplemental Lawton scale is seen here on the right, adding into that the A, B's, and C's, the age, the bleeding, and the compactness. This gets at sort of our surgical risk. And if we go back to that initial Spezzo-Martin paper, you can see that the Spezzo-Martin grade really does correlate well with surgical outcomes. So low grade lesions, 1 to 3, morbidity 0 to 5, mortality 0 to 4. Okay. However, if you get into a grade 5, we're talking much worse. So mortality up to 40%. Okay. So, and there have been a number of papers written, most recently by Lawton and others, trying to say, well, maybe if you're really experienced, you can push the envelope and go to higher grades. Maybe if you're really, if we subdivide X, Y, and Z, we can figure out which ones we can take out. The answer is largely no. These high-grade ones are often really bad, and unless your back's up against a wall, you're probably best using multimodal treatment or leaving them alone. Okay. Here's a what that looks like. So a small frontal AVM. I'll show you. This is endovascular embolization of it. This is one that you could treat either endovascularly or surgically with good effect. This is an 18-year-old male presented with seizures, has a large parietal occipital AVM, Spencer Martin 3, previous staged embo, and patient's currently on Keppra, admitted for another embolization. So here we can see what that lesion looks like. Again, parietal occipital, young patient. This is one that we're probably going to want to treat. We tend to do staged embolization. We're not going for broke in one session. We're going to sort of whittle it away over time until we don't have any good arterial feeders. And then we have transvenous options, surgical options, radiosurgical options to get rid of the rest of it. This is what it looked like initially. It's been whittled away a bit. And so here you're gonna see sort of that next stage. We're going in through an arterial, through a vert feeder, and we're going to go out distally into the PCA. You can see that we want to get our catheter out as far as we can, as close to the nidus as we can, so that we can push that liquid embolic, in this case onyx, as close as we can to it, as far as we can through it, actually, without actually going into the vein. So we're going to bring up our microcatheter. I'll just skip to this. So we're getting way distal, really far out there. And our microcatheter is going to be able to get out right next to the nidus. And then we do a little micro injection. We make sure that we're only getting the nidus and not getting normal brain. We do a WADA test, injecting, in this case, propofol and lidocaine to make sure that there's not eloquent brain there. And then we're able to go ahead and push the glue. We're using onyx in this case, really trying to make sure that we don't get a lot of reflux along the course of the catheter and pushing it into the nidus. Here you can see it's going nicely into those tortuous corkscrew AVM vessels, and we're able to get reasonable penetration. This is certainly not a kill shot, but it's going to help us to whittle it away. Once we're satisfied that we've whittled it sufficiently, we pull out our catheter, live to fight another day, and we'll take up to maybe 1/3 of the supply at any given time. I skipped over this video, so we'll go back to this one. Here's a frontal one, another young patient. I think this is one of my first cases as an attending that I did. So again, this is one that you could definitely remove surgically in a favorable location, or you could go ahead and glue it. We usually end up doing both. So going up the ACAs, here's an AP, you can see it coming along the pericallosals, going up the callosal marginal, and you can see a massive callosal marginal feeder here going to the AVM. We're able to get our catheter up nice and close to it. And at that point, you can see that we're injecting and we've got pretty good flow into the nidus, okay? From here, we're gonna use glue and BCA, really expensive super glue, and use that to be able to get good nidal penetration. I'm going to skip over sort of all that preparations part, and we'll get to the injection. Glue is a little bit different from onyx. It doesn't flow quite the same way. It tends to break off and fragment, and so you just keep pushing it until it's really not flowing anymore. The problem is onyx is non-adhesive, meaning it's not going to stick the catheter in. Glue is glue. It's going to stick the catheter in. So if you get reflux around the tip of the catheter, game over. That catheter is stuck and you're going to end up needing to cut it off at the access point. So in this case, you keep pushing until you can't push anymore, and then you yank it out, okay? You can see that we're getting pretty good distal penetration through the nidus. You can see that it's kind of flowing through at certain points through the nidus and into the vein. So if you had a precordial Doppler on, you'd hear all sorts of hits as it's going through the lung. The lung is the filter here. It's going to stop all that, the rest of that glue. Don't get a chest x-ray when you're done. You're going to see all sorts of glue in the lung, but that's okay. We're going to go back and get a second pedicle now. You can see that we've taken out sort of the posterior margin of the AVM. Now we're going to go up to the other callosal marginal feeder that we had. And you can see here that we're in a pretty good position. We'll go ahead and prep again for the glue. And we'll move up here. Now we're able to glue this pedicle shut and get okay penetration. This one wasn't quite as satisfying. Ultimately, at the end of the day, there's still a little bit left. So what do? We don't have any good arterial pedicles that we want to go after. So we're going to go ahead and take this patient to surgery, resect it, and ultimately they do quite well. AVM's gone, they're cured, and they do very well. Okay. I think I'm going to skip over the ICH portion. There's a lot of new technology here, but there's more to be written about that. Let's just skip to the end here, and I'd be happy to take any general questions that folks have. That's my whirlwind tour of hemorrhagic stroke. I see one question: preferred glue concentration. So we tend to do about a 33%, and then the art of it comes in. You can use glacial acetic acid to be able to slow the rate of embolization, right? Or polymerization. And so using drops of acetic acid, you can get.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.